Hi everyone, this is Deanna Hunt, and I'm one of the instructors at Mount Carmel. Today we're going to be reviewing aminoglycosides, which are bactericidal inhibitors of protein synthesis. Now the aminoglycosides, they are narrow-spectrum antibiotics that are used primarily against aerobic gram-negative bacilli, but because of their toxicities, indications for these drugs are actually very limited. The agents employed most commonly are gentamicin, tobramycin, and amikacin. So as stated earlier, the aminoglycosides are narrow-spectrum antibiotics that are used primarily against aerobic gram-negative bacilli. These drugs disrupt protein synthesis, resulting in rapid bacterial death. The aminoglycosides can cause serious injury to the inner ears and kidneys, and because of these toxicities, indications for these drugs are limited. All of the aminoglycosides carry multiple positive charges, and as a result, they're not absorbed from the GI tract and must be administered IV to treat systemic infections. In the United States, 7 aminoglycosides are approved for clinical use. The agents employed most commonly, again, are gentamicin, tobramycin, and amikacin. The aminoglycosides, they are bactericidal. Cell kill is concentration dependent. Hence, the higher concentration, the more rapidly the infection will clear. Now, of note, bactericidal infection persists for several hours after serum levels have dropped below the minimum bactericidal concentration, a phenomenon known as post-antibiotic effect. Now, bacterial kill appears to result from the production of abnormal proteins rather than from simple inhibition of protein synthesis. And studies suggest that abnormal proteins become inserted in the bacterial cell membranes, causing it to leak. The resultant loss of cell contents causes the death. Now we're going to talk about microbial resistance specific to aminoglycosides. And the principal cause for bacterial resistance is the production of enzymes that can inactivate aminoglycosides. Now, of all the aminoglycosides, amikacin is the least susceptible to inactivation by bacterial enzymes, and as a result, resistance to amikacin is uncommon. And to minimize the emergence of resistant bacteria, amikacin should be reserved only for infections that are unresponsive to other aminoglycosides. Now we're going to talk about the antimicrobial spectrum specific to aminoglycosides. Now, the bactericidal effects of the aminoglycosides are limited almost exclusively to aerobic gram-negative bacilli. Sensitive organisms are listed here on the slide, and they include E. coli and Klebsiella. Now, it's important to note the aminoglycosides cannot kill anaerobes. To produce antibacterial effects, the aminoglycosides must be transported across the bacterial cell membrane, a process that is oxygen dependent. The principal use for perennial aminoglycosides is treatment of serious infections due to aerobic gram-negative bacilli. One aminoglycoside, gentamicin, is used in combination with either vancomycin or a beta-lactam antibiotic to treat serious infections with certain gram-positive cocci, specifically the Enterococcus species, some streptococci, and Staph aureus. Now, the aminoglycosides used most commonly for perennial treatment are gentamicin, tobramycin, and amikacin, as stated earlier. Selection among the three depends largely on the patterns of resistance in a given community or hospital. Now, in settings where resistance to aminoglycosides is uncommon, either gentamicin or tobramycin is usually preferred. Of the two, gentamicin is less expensive and may be selected just based on this basis alone. Now, organisms resistant to both gentamicin and tobramycin are usually sensitive to amikacin, as stated earlier. Accordingly, in settings where resistance to gentamicin and tobramycin is common, you can use amikacin as initial therapy. Lastly, aminoglycosides, they are used topically to treat infections on occasion. Gentamicin and tobramycin can actually treat eye infections, where neomycin can treat infections of the ear and eye. This slide right here talks about pharmacokinetics for aminoglycosides, specifically the three that we've been spending a lot of time talking about. Now, it's important to note because aminoglycosides are polykinetions, the aminoglycosides cross membranes poorly. As a result, very little, about only 1% of an oral dose is actually absorbed, which is why you have to do the perennial treatments, including IM or IV. This table right here discusses the aminoglycosides across the lifespan. Now, when thinking about infants, aminoglycosides, they are approved to treat bacterial infections in those younger than 8 days. This is obviously going to be based on weight and length of gestation. For children and adults, aminoglycosides are considered safe. For pregnant women, there is evidence that they can actually hurt the fetus, so they should absolutely be avoided. In breastfeeding women, gentamicin is probably okay to use, but there's just very little information. And then specific to older adults, caution must be used in older adults with decreased renal functions. As discussed earlier, the utilization of aminoglycosides is limited by the adverse effects. Adverse effects include nephrotoxicity, ototoxicity, hypersensitivity reactions, neuromuscular blockade, and then also the fact that it's only available in an IV or IM infusion or injection. There are some beneficial drug interactions that we need to talk about, and they include interactions with penicillins and cephalosporins and vancomycin. Now, specifically to penicillins and aminoglycosides, they are frequently employed in combination to enhance bacterial kill. The combination is effective because penicillins disrupt the cell wall, as we learned earlier, and thereby facilitate access of aminoglycosides to their site of action. They can also be used with cephalosporins and vancomycin, and like the penicillin, cephalosporins and vanc weaken the bacterial cell wall, and thereby act in concert with aminoglycosides to enhance bacterial kill. Ototoxicity is an important thing to talk about when discussing adverse effects. Now, patients on aminoglycoside therapy should be monitored for ototoxicity. The first sign of impending cochlear damage is high-pitched tinnitus, and it's important to note that ototoxicity is largely irreversible. Now, as injury to cochlear hair cells proceeds, hearing in the high frequency range begins to decline, as discussed earlier. Loss of low frequency hearing develops with continued drug use. Because the initial decline in high frequency hearing is subtle, autometric testing is needed to detect it. The first sign of impending vestibular damage is a headache, which may last for 1 to 2 days. After that, nausea, unsteadiness, dizziness, and vertigo begin to appear. Patients should be informed about the symptoms of vestibular and cochlear damage and instructed to report them. It's also very important to talk about nephrotoxicity in regards to aminoglycosides. Aminoglycosides, they can injure cells of the proximal renal tubules, and these drugs, they're actually taken up by the tubular cells and achieve higher intracellular concentrations. Now, as with ototoxicity, nephrotoxicity correlates with the total cumulative dose of aminoglycosides and high trough levels. It's important to note that high peak levels actually do not seem to increase toxicity. There are a couple black box warnings to be aware of for aminoglycosides. The first is ototoxicity and neurotoxicity. Now, the use of aminoglycosides is associated with irreversible ototoxicity, as we talked about before. Neurotoxic symptoms may also include numbness, tingling, and muscle twitching, and seizures. The risk increases in patients on high dose or with prolonged use, and with patients with pre-existing renal impairment. There's also aminoglycoside nephrotoxicity as a black box warning. The use of aminoglycosides is associated with nephrotoxicity, and this risk again increases with high doses and prolonged use. Lastly, there's aminoglycoside-induced neuromuscular blockade. Aminoglycosides can inhibit neuromuscular transmission, causing flaccid paralysis and potentially fatal respiratory depression. Now, the dosing schedules of aminoglycosides has actually changed some. Now, systemic aminoglycosides may be given as a single large dose each day, or as 2 to 3 smaller doses. Several studies have shown that once daily dosings are actually just as effective as divided doses and probably safer. Because once daily dosing is both safe and effective, and it's easier and cheaper than giving it in divided doses, once daily dosing has become the preferred schedule. However, this schedule is not appropriate for all patients, including neonates, people who are pregnant, undergoing dialysis, and patients with ascites. With these drugs, you do need to monitor serum drug levels. Monitoring serum drug levels provides the best basis for adjusting aminoglycoside dosages. To produce bacterial kill, peak levels must be sufficiently high. To minimize ototoxicity and nephrotoxicity, trough levels must be sufficiently low. Now, when blood samples for aminoglycoside levels are being drawn, timing is very important. Samples for peak levels should be taken 30 minutes after given an IM injection or after completing an IV infusion. Sampling for trough levels depends on the dosing schedule. For patients receiving divided doses, trough samples should be taken just before the next dose. For patients receiving once daily dosing, a single sample can be drawn 1 hour before the next dose. The value should be very low, preferably close to 0. This slide depicts plasma gentamicin levels produced with once daily dosing versus divided dosing. Plasma levels with both regimens are high enough to produce good bactericidal effects. The shaded area indicates levels that are low enough to permit washout of the drug from vulnerable cells in the inner ears. Note that with once daily dosing, levels in the washout range for over 12 hours versus a total of only 6 hours when divided doses are used. As a result, ototoxicity and nephrotoxicity are lower with once daily dosing. Now we're going to spend a little bit more time talking about gentamicin, which is used to primarily treat serious infections caused by aerobic gram-negative bacilli. Primary targets are listed on this slide. Now in hospitals where resistance is not a problem, gentamicin is often the preferred aminoglycoside for use against these bacteria because it's cheaper than the other alternatives. However, resistance to gentamicin is increasing, and cross-resistance to tobramycin is actually common. In addition to its use against gram-negative bacilli, gentamicin can be combined with vancomycin, a cephalosporin, or penicillin to treat serious infections caused by certain gram-positive cocci. Now we're going to spend a little bit more time talking about other aminoglycosides, including tobramycin and amikacin. Tobramycin is similar to gentamicin with respect to use, adverse effects, and interactions. The drug is more active than gentamicin against P. aeruginosa, but less active against enterococci. Tobramycin is used for patients with cystic fibrosis. Like all the other aminoglycosides, tobramycin can injure the ears and kidneys. Now, amikacin has two outstanding features. Of all the aminoglycosides, amikacin is active against the broadest spectrum of gram-negative bacilli, and it's least vulnerable to inactivation of bacterial enzymes. Listed here are key prescribing considerations for aminoglycosides, many of which we've already discussed. Lastly, listed are the common therapeutic uses, the preparation, please note that most of them are IV, and the usual doses.